ILD Community Network, if you haven't logged on to their website, it's wonderful. There's a lot of resources there and videos and education. Linking APPs with ILD experts in alliance with REP. And thank you to our founding sponsor, BI. So uncovering the clues, a case-based journey through ILD and rheumatic disease. And I will say that I have learned several things going through the initial slide deck, and the patient cases are very helpful. Mm-hmm. So case one, it says, I thought RA was about joints, and this is recognizing and managing rheumatoid arthritis-associated ILD. So this is our patient named LBJ. He's a 67-year-old male. He comes in complaining of increasing fatigue and shortness of breath with mild exertion over the past 6 months. Medical history, diagnosed with seropositive RA approximately 4 years ago. So here's a patient who, for 4 years didn't have any mild exertional dyspnea, and all of a sudden for the past 6 months, he's more fatigued and short of breath. Rheumatoid factor really high, 300, greater than 300, and a high anti-CCP of greater than 60. He was started on methotrexate for his RA, and adalimumab added 2 years ago, giving his ongoing disease activity. So what features in this history suggest a higher risk of ILD? Well, again, 4 years ago, he had RA, and up until 6 months ago, he's now getting more fatigued, and just with mild exertion, he's short of breath. So that's a clue that something may be going on in his lungs. And patients with high titer rheumatoid factor and anti-CCP antibody are at higher risk of developing ILD. In the past, we used to have that thought of methotrexate might be causing issues in the lungs, but that, has changed over the past many years. We used to say, let's get them off methotrexate. But the thought now is looking at patients with the rheumatoid factor anti-CCP are at higher risk for ILD. And Stephanie, please chime in if you have any questions. So he goes to primary care initially. He has inspiratory crackles on auscultation. Very important to always listen to the lungs, and I know we do. In pulmonology, of course, and in the rheumatology clinic. He has a normal O2 sat at rest. He desaturates with just walking. Chest x-ray, he has interstitial markings. Initial test ordered PFTs. His forced vital capacity is at 65%. DLCO is 41%. He has a high resolution CT scan with basal predominant reticulations with honeycombing, which is consistent with a UIP pattern. Now, I wasn't familiar with chest before the guidelines, but of course, ACR. The guidelines recommend, what do they recommend next for suspected RA-related ILD? So I did look this up because of chest I wasn't familiar with, and they recommend screening patients with PFTs and high-resolution CAT scans. They suggest against using chest x-rays, bronchoscopy, or the 6-minute walk test for screening. Stephanie, hi, Yusuf. Any questions on that? Why they don't recommend bronchoscopy? I think we went over these reasons when we did the in-person program. Right, Christine? Mm-hmm. Right, okay.
Yes. I think, the high resolution CT is probably the best, would you say?
It's the gold standard.
Okay.
Yeah, definitely. All right, so this patient is for confirming diagnosis and multidisciplinary evaluation. We refer over to pulmonology, and they go over to see Christine in clinic. The diagnosis is confirmed. It's RA-related ILD with UIP phenotype, and we looked at all those different phenotypes that puts patients at higher risk of progression and non-responsive to treatment. Patient, again, as a reminder, methotrexate for 4 years and adalimumab was started 2 years ago. The high titer rheumatoid factor. He's at older age, male, and has a high anti-CCP positivity. This puts the patient all at a higher risk profile. So, what baseline and follow-up assessments would you establish for this patient? How often would you do a PFT? How often would you do a high-resolution CT scan? How often would you see him back in clinic?
From a pulmonary perspective, we would see them usually every 3 to 4 months in clinic with PFTs and walk testing. And the walk testing is nice because we can assess for oxygen requirements, but we can also see kind of functionality wise if they're able to walk further than they did last time, not as far as they did last time. So it kind of can compare the previous testing. And then we usually don't do CT scans unless we are following up on nodules that they had, or if we are assessing response to treatment, if we just start treatment, or if something were to change in a negative way. Even though the amount of radiation isn't huge with these new technology HRCT scans, we do want to minimize exposure to radiation. So if we don't need one every year, we could probably push it out every couple of years. And so we just need to manage the expectations with the patient to say, we don't need to look at your lungs every year because we have breathing tests, walk testing to show us the functionality. And your CT is probably not going to change much visually if it hasn't changed at all on PFT testing.
And very important when we're seeing them in the rheumatology clinic, ask them, are they still at their baseline from where they were the visit before? More shortness of breath? Is the fatigue worsen? Listening to their lung sounds. Should methotrexate be continued in this patient? For me, I would say no.
Agreed. We usually kind of get people off of methotrexate if they end up in our clinic and they've been on it for a long time. And it's possible that some of that could have, led to this. It doesn't happen in everybody, definitely. But, it's one of those low-lying fruit that we can get rid of and then maybe switch to something different.
So it just gets it off the table and out of the way so we know it's not contributing.
Yeah.
All right. Hang on 1 second. There we go. So treatment decisions and evidence-based management. So the therapeutic strategy is to initiate it on nintedanib.
Yep.
Nintedanib. So,
Yeah.
right. Continue on low-dose prednisone, but only for short-term use.
Mm-hmm.
This patient was switched from adalimumab to Betasept for RA control. Methotrexate was stopped. Update their vaccines, pneumococcal, influenza, COVID-19 booster, and then ongoing monitoring of the PFTs every 3 to 6 months, as said earlier, and the high-resolution CT at 12 months. What evidence supports antifibrotics in RA-ILD? I think I took a look at some randomized clinical trials that show that certain antifibrotics slow the decline of the FVC in patients with ILD. Christine, anything different there in real world data and evidence?
Yeah, no, as soon as you see a UIP pattern on CT scan, that to us tells us that it is mostly a fibrotic process, especially when you see honeycombing as well. And so that is just going to beget more scarring over time. And so it's best to get the antifibrotic on board so we don't lose lung as quickly as we could if we're not treating it. So as soon as you see UIP pattern, always think antifibrotic therapy.
Thank you.
Mm-hmm.
And what biologics might be preferred? Let's start thinking about first line in this patient. Maybe Cellcept, mycophenolate, azathioprine, rituximab.
Mm-hmm.
Right.
Yep.
And then that would be first line. And then I read some literature on cyclophosphamide, maybe next.
Yep.
And
definitely done that.
All right. And then again, just short-term corticosteroids.
Yeah. It just makes you have to see what is driving the the symptom change. So if it is mostly ground glass opacities that are making the PFTs drop and the symptoms of shortness of breath worsen, I would definitely escalate the immune suppression to the rituximab level and above. And then if it's mostly the UIP or the scarring or the fibrosis that's changed on the CT scan, definitely I would mycophenolate azathioprine is probably fine for management of the symptoms, and then adding the nintedanib on top of that for the scarring would be perfect. So I'd like to see, I tell patients all the time, like when you have an autoimmune disease process, you might see two different processes on CT scan. And so what is changed from last scan, what has increased, and that's the area you need to aim at first.
Thank you. Yusuf or Stephanie, any questions on that?
So far, so good. Thank you so much.
All right. So summary and teaching points on this case. High-risk RA patients need proactive ILD screening. RCT and DLCO play critical roles in early identification of ILD. UIP pattern carries a poor prognosis. Antifibrotics can slow the decline. And cross-specialty care with shared decision-making is essential. And we're lucky to have that at Duke, that we have so many specialists. But some people out there in the community don't have that. So maybe the pulmonologist is taking care of the RA and the ILD and vice versa.
Mm-hmm. It's true.
All right. Christine,
All right.
would you take this one?
So case number 2, it's getting harder to breathe. So progressive ILD in systemic sclerosis. And I can't advance the slide, so you're going to have to do that.
Okay. Sorry.
Sorry. So we have a 56-year-old Caucasian woman here, comes in, let's say to my clinic, worsening dyspnea over the last 6 months with a dry cough, not productive of much of anything. History, known diagnosis of diffuse cutaneous systemic sclerosis, for about 2 years now. So she's just been getting progressively more short of breath and has a lot more cough recently. All right, so clinical features. She's got some skin thickening proximal to elbows, Raynaud's and GERD, antibody profile positive SCL70. So what is her risk of developing ILD? So I would say she's got the positive SCL70 with known systemic sclerosis. And that's my dog, I apologize. She wants to go outside. And she's got this worsening shortness of breath over the last 6 months and a dry, hacky cough. So all the bells and whistles go off in your brain for there's possibly an interstitial process going on here, maybe progressive fibrosing or progressive lung disease at that point. So what baseline screening would you pursue, Yusuf or Stephanie?
Imaging side, Christine.
Okay.
I would go with CT-ILD protocol.
Okay. And do we know what her lung function looks like yet?
No, we don't. So we'll get some PFT studies.
Perfect. So we'll get a high resolution CT scan and PFTs.
Yes.
So let's see what that shows us here.
Christine, are you guys doing CRP also, like looking for inflammation?
Oh, yep. We'll do ESR, CRP. We'll do all those things.
Okay.
And again, that factors into when you get the CT scan results. Is it more fibrotic or more scarring or more inflammatory? And then if it's more inflammatory, do we have markers to back that up to say, yes, it's actually an active process going on? So that's a good
Michele, I think CRP and ESR in our world, in their world, it's PFT and CT-ILD.
Exactly. They were hand in hand, though.
I got that.
Love it. Because we all want to know what's driving it, right? Because that's where you need to do the treatment. So worsening dyspnea over the past 6 months, desaturation on exertion. Most of our patients at rest have a wonderful oxygenation above 90%. It's when they start to move and use their muscles that's when the oxygenation goes down. So it's usually desaturation on exertion. So PFT show an FVC of 71%, DLCO of 52%, which is downtrending from baseline. HRCT, early honeycombing with UIP pattern. And as soon as you see the word honeycombing, that is equated to fibrosis. So this is becoming a more more of a fibrotic pattern than it was in the past. So what are we going to do next in management?
Antifibrotics, right?
Usually if we have honeycombing, if you see honeycombing in a CT scan, that's, it's an equal sign. A lot of at least the chest radiologists are trained to spot it and then trained to write down when it's not there. So they will say no honeycombing because it is that much of an equal sign. So next steps would be to start an
Indefinite.
Is that your number one choice?
Which one, nintedanib?
Yeah.
I will tell you, it is the only one that was studied in progressive ILD.
Okay.
So in IPF, nintedanib or pirfenidone are therapy options, but in progressive ILD, only OFEV was studied. So that's the one we have to go to. And then hopefully this new one that just came out, the nerandomilast, will be FDA approved, hopefully in January or February, that we can add on at that point.
The only thing that has as a side effect, like annoying, is diarrhea, right?
Yes. And you know what? I had a patient today on OFEV for the past 6 months. Do you know that he has constipation as a side effect?
Oh,
I was shocked, utter shock and awe.
wow.
I congratulated him on that because it was like a rarity, a rarity. All right. So, weird question. Would you initiate treatment or refer to transplant?
Both. I mean,
agree.
I would not hurry with the transplant referral, but I'll do both.
I agree, both, because it's never too early to refer someone for transplant, especially if they desaturate with exertion. So we already know that our lung function has declined, and it will just continue to decline, especially if it's got some scarring in there. So it's good to get them in to see transplant, especially if they're of a good age and they're healthy enough to do it. But it's good to get them in early before they get too sick to survive it. So I do both. All right. So treatment, mycophenolate initiated. So we still have this autoimmune process, referral to transplant clinic for consideration, and reviewed vaccine needs, and then introduce palliative care. So as soon as they saw honeycombing on CT scan, they realized that this is a progressive process, and they've already started to talk about palliative care. It might be a little early for this person to have that conversation because then you start to really scare them. But it's always good to keep in the back of your mind that it is something that should be introduced at some point in time, especially if they continue to progress. I can't guarantee how fast someone's going to progress, but when they do start to progress rapidly, it's a harder time to have those conversations. So what role do non-pharmacologic interventions play here? Like, can you think of any that could be helpful to lung patients and autoimmune patients?
Pulmonary rehab.
That's a big one.
O2 therapy.
Yep, oxygen. And then one's already on here.
Vaccinations?
Your vaccination. So I did my DNP project on supportive care measures for the IPF patient. Basically, that's a progressive ILD patient as well. And it was supportive care. So it was vaccines, pulmonary rehab, lung transplant referral, sleep apnea, kind of monitoring, and then pulmonary hypertension, because those all things can happen when we have lung disease. And so it's good to manage all of those issues because they can all lead to progression of ILD at the end of the day if they're not very well managed. So it's good to have a holistic kind of treatment plan in mind for these patients, not just medication.
So let me ask you a quick question, Christine. Are you guys doing a baseline echo if they haven't had one?
Yes.
Okay.
Yes. And then if their diffusion capacity were to drop and their FVC stays the same, then we would update that echo because it can definitely change over time. And many things can alter a DLCO, like anemia or some other things that I can't think of off the top of my head. But pulmonary hypertension is one of those ones that's fixable if we can get it early enough. So it's super important to do. So then how do you monitor and adjust therapy?
Regular follow-ups, CT imaging,
Yeah.
PFT studies.
Perfect. And then, bring them back to clinic every 3 to 6 months, hopefully coordinated with their rheumatology appointments if they're seen conjunctively here at Duke. It's hard when we have different attendings and different practitioners that have different days of the week, but we try as much as we can to get them in the same time. But yeah, we do that every 3 to 6 months, and then we can, whoever wants to do blood work can do blood work to monitor. But those all sound like good ideas.
Michele, I'm getting good at this.
I'm enjoying it.
Christine, if you need help over there, let me know. I'll apply.
Come on over. All right. So summary and teaching points. So recognizing high-risk ILD and diffuse systemic sclerosis, importance of early recognition of progressive fibrosing ILD. Time is lung. We cannot get these lungs back if they start to get scarred. Initiating immune modulator therapy and timing of antifibrotic therapy, and then timing of referral for transplant and use of antifibrotics. Now, the transplant team, if they think they're getting close to the window of being transplanted, they will stop the antifibrotics, and we are fine with that. We just want to make sure that if they are in the process of being evaluated and then they get turned down, they stay on the antifibrotics as long as they can. So I'm fine with them stopping it if they know they're going to be listed, because when you get listed at Duke for a lung, you get one within a month. So it's quick.
Really?
Mm-hmm. Sometimes I had a patient come in on a Tuesday and they got transplanted that next Sunday.
Oh my goodness.
So it's a really quick. A lot of our patients only get one lung, so it makes it a little easier, but it's a quick turnaround.